I suppose from a standpoint of age, it makes sense to present pediatrics first. Although, as you'll see as I talk, often our approach to establishing clinical approaches to this works the other way, where we have kind of a trickle-down effect from adult medicine, where there are often more data, to pediatrics, where the evidence base is often slimmer. So those are my disclosures. So an old slide, but showing the relationship of systolic blood pressure to both myocardial infarction and stroke, indicating that there is clearly a relationship there between blood pressure and outcomes in adults. And we know that in adults, there are a whole range of cardiovascular complications of hypertension, and this really makes the rationale for why we should aggressively identify it and treat it in adults. And the question has been, how should we think about this in the pediatric age range? And I'll give you a sense of what we know about that and what our knowledge indicates in terms of identification and treatment. So some of the most compelling data come from the Bogalusa study. This is a study of children who had risk factors identified during school age and then followed over time. And they did what is often called the pathology study, where they, as some of these individuals aged, they died of accidental causes, which allowed them to then do autopsies and look at cardiovascular disease, look at atherosclerotic lesions, and compare that to risk factors in earlier life. And here's an actual picture of the arterial lesions in red, and this happens to be a young individual who smoked and who had elevated blood pressure. And you can see that the blood pressure was associated with the presence of these lesions. It was higher, both systolic and diastolic, for those who had the lesions compared to those who did not. The Bogalusa study also looked at the issue of clustering of risk factors, and I think, as Jan mentioned, there will be a new set of guidelines published in Pediatrics in December, and the focus of those guidelines is actually thinking about this in a more integrated way. So really combining all of the different risk factors that we're concerned about. And again, here are data from the Bogalusa study, and you can see whether you're talking about the early fatty streaks or the later fibrous plaques, an increasing number of risk factors is associated with increased coverage, both in the aorta and in the coronary arteries. And you can see, especially for the coronaries, these multiple risk factors seem to be especially important. Now, this is an actual headline from the paper. I think this was a paper presented a number of years ago at the American Heart Association, but actually it turns out that hypertension may have substantial neurocognitive effects, and we know that in adults, but we also are now starting to learn something about this in the pediatric age range. So Mark Landy, who's from the University of Rochester, looked at N. Haynes data and looked at these measures of neurocognitive function in children and related them to whether the blood pressure was elevated or not. And here's what they found, and it's a complicated slide, but basically what you can see is that each of these tests was less good in the patient who had systolic blood pressure above the 90th percentile compared to those who had normal blood pressure. Adding to our knowledge about the ill effects of blood pressure. And then we know that mosquitoes don't like high blood pressure either. So it raises the question about how should we approach blood pressure in children and adolescents in a clinical setting. So the first issue, I think, is when should blood pressure be measured? And the recommendations are that we measure blood pressure pretty much any time a child or adolescent over the age of 3 sees the physician. And we need to use those opportunities to have a better sense of what the blood pressure is doing over time. Now, another question that comes up is what's the recommended method for measuring blood pressure? And this is tricky because we have more and more automated devices in our clinical settings. But the truth is auscultation remains the gold standard, and remains the standard on which all of the blood pressure normative data are developed for children. And so this is probably the best way to measure blood pressure. And there are some important issues which you have to take into account when you're measuring blood pressure. And this is especially, it's true for adults, but it's especially true for children who are substantially more difficult to measure blood pressure in. You need to know that the task force standards for blood pressure are for seated blood pressure. We'll talk about the cuff size in a minute. That's critical. You want the arm extended at heart level and supported by a solid surface. And you want the proper deflation rate, which is actually a very slow deflation rate, so that you can get an appropriate measure of blood pressure. And there's been controversy over where to place the diastolic blood pressure, but it's now recommended that we use the disappearance of sounds for the fifth or the fifth phase for diastolic blood pressure. So the automated devices are everywhere. They're more appropriate, I think, in circumstances where you want to look at trends in blood pressure. I think they're quite valuable there. But they're being used more and more in primary care, and I think the issue here is if you get an abnormal reading using an automated device, you should recheck it using using auscultation. Again, you shouldn't assume that that all healthcare professionals are good at measuring blood pressure, because often they're not, and checking it yourself is actually quite valuable. So here's a slide showing why we need to worry about the cuff size. And the obvious thing is when you're measuring blood pressure, the pressure inside the cuff is supposed to be the pressure that's being exerted on the artery. And if you've got a big arm and a small cuff, then you've got a high pressure in the cuff and less pressure exerted on the artery, and that leads to a situation where you get an artificially inflated blood pressure. And unfortunately, this happens all the time in pediatrics, especially with our adolescents who are more overweight. So paying attention to cuff size is critical. The way to figure out the right cuff size to use is based on the circumference of the arm at the midpoint here. A better way of thinking about it, or an easier way of thinking about it, is that the cuff bladder should essentially encircle the arm and should cover about 2/3 of the distance from the elbow to the shoulder. Now, interpreting blood pressure in children is substantially more complicated than it is in adults, because we know that blood pressure is related to growth and development. And so our new standards take into account the gender of the child, the age, and also the height percentile, because we know all of these factors normally contribute to blood pressure. And then in order to figure out where you stand based on these, obviously you have your measured systolic and diastolic blood pressure. So normal blood pressure would be both systolic and diastolic below the 90th percentile for age, sex, and height. Pre-hypertension would be blood pressure between the 90th and 95th percentile. And we've also indicated that adolescents with blood pressure above 120/80, which would be the level of pre-hypertension in an adult, should also be considered pre-hypertensive, even though these percentiles cross over this point at about age 12 or 13. So we need to pay attention in those early teenage years and start to use the adult cut point for pre-hypertension. Stage 1 hypertension is systolic or diastolic blood pressure greater than the 95th percentile and less than the 99th percentile plus 5. This ends up being about 12 millimeters of mercury above the 95th percentile, and that's the range where we consider hypertension to be stage 2 and to be more of an emergency situation where a more urgent evaluation and treatment scenario needs to be developed. Now here are the tables, and they're complicated. You can see that they go by age. Here are the blood pressure percentiles, 50th, 90th, 95th, and 99th, systolic and diastolic. In this case, these are for boys. And here are the height percentiles. And you can see just by looking at the table that even controlling for age and for gender, blood pressure systematically increases with height percentile. So it's important to take this into consideration to make the most accurate determination. Now the good news is these are being integrated more and more into electronic medical records, making it much easier for the clinician in primary practice to utilize these. We use Epic, which is an electronic medical record in our hospital that now has these integrated, but also gives alerts when blood pressure is above the 95th or the 99th plus 5 percentile. So it's very helpful in terms of decision making. So what's the prevalence of hypertension in children? This is something that's been discussed a lot, and generally it's been considered that the prevalence is about 1% of kids. Now you would think that seems wrong, because if the definition of hypertension is the 95th percentile, shouldn't 5% of kids have elevated blood pressure? The problem there is that what you need is persistent elevation of blood pressure. So while on a first reading you would tend to get 5% above the 95th percentile, on subsequent readings that group will diminish, and the general wisdom was that you would end up with about 1 to 1.5%. Now, there are some interesting things happening in our population that we need to be aware of. And so a guy by the name of Muntner and his colleagues did a study where they looked at NHANES studies and tracked these studies over time to see if blood pressure was essentially staying the same, going up or going down. And what he found was that the average systolic and diastolic blood pressure is increasing in children and adolescents, and much of this increase is attributable to the epidemic rise in obesity. So that as we're having more obesity, and I'll talk about that tomorrow morning, in our population, we're also getting more higher blood pressures. And so, as I said, the thought process was that the prevalence was thought to be about 1 to 2%. But a study done by John Soroff in inner city Houston showed that actually with obesity and with some other factors that we may or may not understand at this point, we're seeing a very different scenario in recent time. So they found actually 19% had elevated blood pressure on their initial reading. This whittled down to 9.5% with the second screening, and down to 4.5%, which would be the definition of hypertension on the third screening. So the more recent thinking is that we may have a prevalence of hypertension that is as high as 4%, which makes it a substantial issue for primary care, pediatrics, and family medicine. Now, the other question that comes up is, what is the cause of hypertension in children? And the historic wisdom, which as you'll see turns out not to be so wise, is that hypertension is almost always secondary in pediatrics. And you can see here a variety of different potential causes: essential or primary hypertension here, renal disease, which has been thought of as a very common cause of hypertension in children, and you can see endocrine causes, etc. So how does this play out? Well, when we look at studies of adults, you can see that essential hypertension makes up about 95% of the diagnoses of hypertension. And so the question is, how do kids look in comparison to that? And it turns out the answer is it depends on where you look. So here are 3 older studies, one from Toronto, one from London, and one from New York. These are individuals, young individuals, who were hospitalized for hypertension. And you can see that essential hypertension actually was relatively uncommon in these early studies. And that's what led to the thought that most hypertension was secondary. But when you think about it, this is really a highly referred group. They were hospitalized, so they had very severe elevations of blood pressure and probably don't represent the population-based situation. Here's a slightly different view. So here's a preventive cardiology clinic at the University of Michigan, and you can see here essential hypertension made up about 50%. And there were some renovascular, some coarctation, some renal disease that made up the other percentiles. But again, this may not be the right story either, because this is, again, a referral population. So here's an interesting study that was done way back in the 1970s. And this was a study done in a primary care setting, done in St. Louis. And what's interesting is what they found is that primary hypertension makes up about 95% of hypertension in pediatrics. And there have been some subsequent studies that have shown this. So it turns out that actually essential hypertension or primary hypertension is the main cause of hypertension in children. But there are some caveats there. So it depends on your age. So if you're very young, the likelihood of a secondary form of hypertension is much higher. And that's where renal disease, coarctation, et cetera, may be quite important. When you get to adolescence, primary hypertension is much more common, and often these days based on both a family history of hypertension and often in the setting of obesity. And it's been shown in a number of studies that especially in this setting with obesity, actually systolic blood pressure elevation is much more common than diastolic blood pressure elevation. So when should you be concerned about secondary hypertension? I think the point is if your patient presents with higher blood pressure, stage 2 hypertension and above, if they're younger, and if you find less family history of high blood pressure, this is a patient that probably deserves more extensive workup. Now, this is the algorithm that was developed by the National Heart, Lung, and Blood Institute for managing hypertension, and I'll just spend a second on this. Obviously, the key here is to measure blood pressure and to categorize it correctly. And depending on this categorization, that determines where you go with your workup. If you have stage 2 hypertension, you really need to look for both target organ damage, and I'll talk more about that in a second, and you also need to look for the potential for secondary forms of hypertension. And this is a patient that may deserve referral to someone with greater expertise in pediatric hypertension. Certainly overweight is still an issue here. If you're in the stage 1 group, as you'll see, the diagnostic workup is relatively minimal. The consideration for secondary hypertension is much less, and we see much more primary hypertension in this arena. Much of it is related to overweight, so the focus on overweight there. And there needs to be an assessment of target organ damage here too. And our best way of assessing target organ damage right now is to look for left ventricular hypertrophy using echocardiography, and we'll talk more about that in 1 second. If you're in the pre-hypertensive range, the question is which direction are you going to go in? And again, these are patients who deserve closer follow-up, but we need to figure out if they're heading towards stage 1 hypertension. And there's recent data that suggests that about 7% of these patients with pre-hypertension per year will advance to stage 1 hypertension. But some of these actually end up being in the normotensive range over time, and those are especially patients where lifestyle changes can be successful. So if they moderate their weight gain and if they do some other things, they may actually end up over here. Now, the diagnostic tests for children with hypertension, as I mentioned, are relatively straightforward. UA, CBC, BUN, creatinine, lipid profile, and I'll talk about that later this afternoon, really looking for that clustering of risk factors that seems to be so important. And then if you're concerned about a secondary form of hypertension, you can use your history and physical examination to essentially drive your workup for those causes. So how do we treat hypertension? Well, it's important to emphasize that the mainstay of treatment of hypertension in kids is lifestyle change. So the idea is, and this is especially true with those kids with pre-hypertension, but also true for stage 1, is that we want to focus on things that they can do that can keep them off of medication to treat their hypertension. And these would include weight reduction. Many of our patients with hypertension are overweight. It includes increased physical activity and a variety of dietary interventions, usually focused on a DASH type diet, and I'll show you some data in a second that indicate that actually this may be quite beneficial in children and adolescents. So we know that weight reduction is very helpful in adults, and we know that it's incremental. As you decrease your overweight, you can improve your blood pressure, both systolic and diastolic. There may be a threshold. You may have to lose a certain amount of weight to start to see this decrease. There might also be a floor, but in general, this weight reduction is very important. Exercise also can be important. It's especially important because it's an important part of weight management. And it turns out that while dynamic is probably the most effective kind of exercise in this regard, resistance training can also be beneficial, both in terms of dealing with weight issues, but also in managing blood pressure. Sodium restriction appears to be useful, at least in some individuals, and there have been studies that show that our consumption of sodium is far in excess of what we need, and that's especially true for adolescents. And I think it's a beneficial thing to try because there seem to be few adverse effects from lowering your sodium intake from where it is in our current environment. And it may have a beneficial effect, especially for some people who may be more sensitive to salt. Here are the foods that are high in sodium, and this could also be called, this slide could be called the typical diet for children and adolescents. It's everything, and it comes from lots of places that people don't expect, like cereals, etc. And so, you know, it turns out that Cheerios are a high sodium food. So these are things that we need to be concerned about. And most patients will tell you, I don't have a problem with salt, I don't add salt. The mother will tell you, I don't add salt when I cook. And the point is they don't have to, because it's already included in pre-processed foods. Now, here's the study I mentioned about the DASH diet, and this was a randomized controlled clinical trial. It was a small study, only 57 adolescents, but basically they were randomized to get the DASH diet or routine care. And then blood pressure was assessed at baseline. After 3 months of treatment, they then went off treatment, and blood pressure was assessed at 6 months. And what we found was that those in the DASH diet group had a greater decrease in systolic blood pressure from baseline compared to those in routine care, while diastolic blood pressure stayed about the same. What's interesting is this occurred without a reduction or a difference in weight between the DASH group and the control group. And those in the DASH group did have greater intake of fruits. We didn't do quite as well with vegetables, but they had increased potassium and magnesium and a greater decrease in total fat. So we did seem to have an impact on their diet. And so we can say that it improved both their diet and their systolic blood pressure. There's actually an ongoing study right now looking at this in a more robust way with a larger number of subjects. So we'll have more information in the next couple of years. What about antihypertensive medications? And so we have a couple of things that we have to talk about here. One is these are for when therapeutic lifestyle changes are not working, and usually when there's evidence of target organ disease. And this is rare. It's rare to have signs or symptoms related to elevated blood pressure. I wanted to spend just a couple of slides talking about left ventricular hypertrophy, because it turns out that this is our best measurement of target organ damage. And it's interesting because these are factors that are all associated with left ventricular hypertrophy, but left ventricular hypertrophy also seems to have an independent effect on cardiovascular disease outcomes. So a study by Gianni DeSimone showed that a level of 51 grams per meter to the 2.7 power in terms of left ventricular mass index had a 4-fold greater increased risk of cardiovascular endpoints. These are adults with hypertension. So we asked the question, do children have this level of left ventricular hypertrophy or not. And so these were 130 individuals aged 6 to 23. And as you can see, we actually had 8% of our patients who were at that level that would indicate a fourfold increased risk for cardiovascular disease in adults. And if you look at this, most of our patients were actually above the 90th percentile for left ventricular mass index, suggesting that hypertension is already having a substantial effect on these kids. Now, we know that a severe LVH can happen, and we know that early recognition and treatment of hypertension may be important. We now have early data suggesting that treatment of hypertension actually can reduce left ventricular mass in children and adolescents. So you'll hear more about the pharmacologic treatment in adults, and there's a lot more data about how to pick an agent. But the idea is that we can pick from virtually any class. The usual classes that we choose are actually the ACE inhibitors and the calcium channel blockers these days. But the idea is that it may not, your initial drug and dose may not always work, so you may need to switch classes, you may need to increase the dose, and ultimately you may need to use more than one antihypertensive agent for those who have more substantial hypertension. The goal is to reduce blood pressure below the 95th percentile, and obviously using the least amount of drug necessary to accomplish that. In patients with diabetes or renal disease, we're more aggressive, and we actually aim to reduce the blood pressure below the 90th percentile. And this may take more than one medication to accomplish that.